So you walk into your patient's room for the very first time, right? And you pick up their chart. And you just see this massive, honestly highly intimidating list of oncology medications.
Oh yeah, it's a lot.
It is. You scroll through the potential side effects, and it feels like you literally need to memorize a 1,000-page textbook just to keep this one patient safe for your 12-hour shift.
Right, it's incredibly overwhelming,
Yeah.
especially when you are newer to the unit. The sheer volume of information can cause this absolute paralysis at the bedside
Yeah, totally.
because you have this really complex pharmacology, you have a fragile patient, and, there's this creeping terror of making a fatal mistake simply because you forgot a specific drug interaction.
Exactly. But there is a secret to understanding all of this without relying on rote memorization. And that is what we are unlocking today. So welcome to the Super Nurse Podcast.
We're so glad you're here.
I am guiding you through a curriculum that was created by Brooke Wallace. She is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. Now, I am not Brooke Wallace.
Right, we want to make that clear.
Yeah, but we are building this entire conversation directly from her bedside knowledge, her personal clinical notes, and her incredible teaching style. We're doing this to help you, bridge that massive gap between what you read in nursing school and what actually happens in real patient care.
And today's goal is breaking down the nursing priorities for managing cancer treatment side effects. We are looking exclusively at the why behind the symptoms.
Which is so important.
It really is, because when you understand the underlying mechanism, well, your nursing interventions stop being these arbitrary lists that you just cram for the NCLEX. They transform into logical, life-saving bedside actions.
Absolutely. And a quick note, we highly recommend you subscribe and watch the incredible comic book-based video for this topic on YouTube. The link is right there in the description, and this channel is called Super Nurse Comics.
Super helpful.
It really visually maps out everything we're about to discuss. So before we look at specific symptoms like, a fever or nausea, we really have to establish what these treatments are actually doing on a cellular level.
Yeah, that is the foundation of oncology nursing. I mean, you cannot anticipate a clinical problem if you don't understand the weapon that's being used. And chemotherapy, fundamentally, is a blunt instrument.
Meaning it doesn't just, neatly snipe the cancer?
Not at all. It is systemic. Chemotherapy is designed to hunt down and destroy rapidly dividing cells.
Right.
So the core problem is that this blunt instrument, it cannot distinguish between a malicious, fast-growing cancer cell and the normal, healthy, fast-growing cells your body requires to function every single day.
Wait, okay, so if chemotherapy is specifically hunting fast-growing cells, I assume that's why we don't typically see it destroying, the heart muscle or the brain tissue, because those cells aren't rapidly dividing?
Right. That's a really brilliant synthesis, yeah. Cardiac muscle cells and neurons in the brain, they divide very slowly, if at all, in adulthood. So they largely escape the primary crossfire of traditional chemotherapy.
Oh, wow, okay. That makes so much sense.
But the areas of the body that rely on constant cellular turnover, they are absolutely devastated. Hair follicles, the mucosal lining of the gastrointestinal tract, and the bone marrow.
Because they're the fastest growing normal cells in the human body?
Exactly. They become collateral damage.
So they are essentially doing exactly what they are programmed to do, which unfortunately just paints a massive target on their backs. Let's look at the bedside reality of that, starting with the hair follicle.
Yeah, alopecia.
Right, alopecia or hair loss. It is so highly visible and just profoundly traumatic for a patient. Since clinical experience shows we can't stop the chemo from attacking those follicles, how does a bedside nurse actually intervene here?
Well, we manage the psychological fallout. What we know from practice is that the most effective nursing intervention actually happens weeks before a single hair falls out.
Really? Before it even starts?
Yes, we call it anticipatory guidance. You sit down with the patient and you encourage them to cut their hair short and, shop for wigs or headscarves before their first infusion even starts.
Oh, I see. So they can match their natural color and style while they still have it.
Exactly. And more importantly, it gives them back a critical sense of agency. Because, cancer strips away a patient's control over their future, their schedule, and their body.
Yeah, that's devastating.
It is. So
Yeah.
taking charge of the hair loss before it happens, it helps preserve their identity in a situation where they feel like they're just losing their own reflection.
That reframes it entirely. It's not just a physical side effect, it's an identity crisis. Okay, so if hair follicles are the first casualty, The next fast-growing area is the gastrointestinal tract.
Oh yeah, the GI hit is massive.
Right, from the mouth all the way down to the intestines, that lining is constantly replacing itself. So it makes logical sense that the GI tract takes a huge hit, which leads to severe nausea. But this isn't just a normal stomachache from eating bad takeout, is it?
No, not even close. The pathophysiology is incredibly intense. When the chemotherapy breaks down the intestinal lining, those dying cells release massive amounts of serotonin.
Wait, serotonin? Like the mood chemical?
Yeah, but in the gut, serotonin acts as a powerful distress signal. It binds directly to the vagus nerve, which runs from the digestive tract straight up to the brain, basically screaming that the body is under attack.
Oh, wow. But the attack is happening on two fronts, right? Because while the gut is screaming through the vagus nerve, the chemotherapy drugs are also crossing the blood-brain barrier.
Exactly. They directly stimulate the chemoreceptor trigger zone, the CTZ, up in the brain.
So the brain is essentially tasting the poison in the blood.
That is a perfect way to describe it. And that triggers a violent systemic neurological response. The brain detects these toxic chemicals, and it attempts to purge them from the body at all costs.
So the bedside action has to account for that entire neurological cascade. A massive trap I see newer nurses fall into is waiting for the patient to press the call light and complain of nausea.
Definitely.
Or, waiting until the patient is actively dry heaving before they go pull the anti-nausea meds.
And if you wait for the vomiting reflex to initiate, well, you've already lost the battle. Once that cycle begins, it is notoriously difficult to break.
So what's the priority?
The absolute priority nursing action is proactive administration. You administer a 5-HT3 antagonist. Ondansetron is the generic, commonly known as Zofran. And you do this 30 to 60 minutes prior to the chemo infusion even starting.
Okay, so before the poison hits the system.
Yes. You must block those receptors on the vagus nerve and in the CTZ beforehand.
So the rule is proactive, not reactive. Now, that covers the systemic nausea, but the local damage to the GI tract causes stomatitis, right, or mucositis.
Yeah.
The mucosal membranes in the mouth just become inflamed and ulcerated.
Yeah, patients describe it as their mouth literally being on fire.
Which is terrifying.
It is. And the ulcerations can be so severe that patients completely stop swallowing. I mean, they can't eat, they can't drink water.
Which would spiral rapidly into severe malnutrition and dehydration, right?
Exactly. Which just compounds the physical weakness caused by the cancer itself.
This is where bedside teaching completely changes how you view everyday items. Because suddenly, a normal bottle of over-the-counter Listerine sitting on a patient's tray, well, it isn't just mouthwash anymore.
No, absolutely not.
Because of the alcohol and glycerin content, it's essentially a bottle of liquid fire for someone with stomatitis.
Yeah, it would be like rubbing alcohol onto a third-degree burn. It's agonizing. The correct nursing intervention involves meticulous, incredibly gentle oral hygiene. We teach patients to use a very soft bristled toothbrush.
And what about the pain? How do they even eat?
To manage that agonizing pain so they can tolerate just a few bites of food, we administer viscous lidocaine.
Okay, viscous meaning thick, right?
Right. It's a thick, sticky, numbing liquid that coats the oral sores.
Okay, so the GI destruction compromises their ability to eat, but that malnutrition is actually compounding an even more dangerous invisible crisis happening deep inside their bones. We really need to talk about the bone marrow.
Yes, we do. This is the area where nursing vigilance truly becomes a matter of life and death.
So think of the bone marrow as a high-speed cellular factory. It is constantly churning out billions of blood cells every single day. When chemo drops a bomb on that factory and forces a shutdown, the body enters a state of pancytopenia.
Right, which means a lack of all blood cells.
Yeah, pan meaning all, cyto meaning cell, and penia meaning lack of. A devastating lack of everything. Let's break down this triad for the nurse, starting with the drop in red blood cells anemia.
So red blood cells are your oxygen cargo ships. When the chemo destroys the factory making those ships, the patient's oxygen transport system just collapses.
Which leads to profound, paralyzing cancer-related fatigue.
And it is vital for the nurse to emphasize to the patient and their family that this is not normal tiredness.
Right, because sleeping for 12 hours doesn't fix it. The cells literally do not have the oxygen required to manufacture energy. So, what does the bedside nurse actually do for anemia fatigue?
You implement strict energy conservation. You collaborate with the patient to schedule their most demanding tasks, like showering or physical therapy, for the specific time of day when they naturally have the most energy.
Okay, that makes sense.
But here's a critical nuance that often confuses new nurses. You must encourage light activity.
Wait, really? If they're exhausted from a lack of oxygen, shouldn't we keep them on strict bed rest so they don't expend what little energy they have left?
It seems counterintuitive, I know,
Eh.
but prolonged bed rest actually accelerates muscle deconditioning, and it worsens the fatigue.
Oh, wow.
Yeah, getting them up for a short-paced walk down the hallway is absolutely essential to maintain their baseline physical function.
That makes perfect sense when you look at the long game. Let's look at the second part of the pancytopenia triad thrombocytopenia, the crash in platelets.
The mechanics.
Exactly. If red blood cells are the cargo ships, platelets are the mechanics. They plug the microleaks in our blood vessels. When they vanish, the patient loses the ability to clot. So a nurse is basically acting as a detective looking for internal bleeding. But what exactly are petechiae and why is that such a critical assessment finding?
So petechia are these tiny pinpoint red or purple dots on the skin, often around the ankles or on the chest.
Like a rash?
Kind of, but unlike a normal rash, they do not blanch or fade when you press a finger against them. They indicate that the microscopic capillaries under the skin are experiencing spontaneous microhemorrhages.
Because there are 0 platelets available to patch the walls.
Exactly, the vessels are just leaking.
And if they are bleeding spontaneously under the skin, they could be bleeding anywhere. So your bedside action is checking their stool and urine for hidden occult blood.
Yes, constantly.
And environmentally, you have to create a physical safe zone. You must clear the room of any clutter. Because, I mean, a minor bump against a bedside table that would give a healthy person a small yellow bruise that could trigger a massive, life-threatening internal hemorrhage for a thrombocytopenic patient.
It really could.
Ugh.
Which brings us to the third and arguably most terrifying complication of the bone marrow shutdown neutropenia, the catastrophic drop in white blood cells.
The soldiers are gone. The immune system is completely offline.
This is the clinical emergency every oncology nurse dreads. The evidence tells us that for a severely neutropenic patient, a single temperature reading of 100.4 degrees Fahrenheit or 38 degrees Celsius is a blaring siren.
Let me emphasize that for everyone listening. 100.4 is a medical emergency. You do not hand them 2 Tylenol, chart it, and wait an hour to see if the fever breaks.
Please don't. If you do that, the patient could be in irreversible septic shock before the end of your shift.
So what's the protocol?
The standard of care is rigid. The moment you see 100.4, you immediately draw blood cultures to identify the invading organism. And you must have broad-spectrum IV antibiotics hanging and infusing into that patient within 60 minutes of the fever spike.
Because time is tissue and time is life.
Exactly.
It completely shifts how you view the patient's environment, too.
Right.
This is why we have strict rules, like absolutely no fresh flowers or potted plants in a neutropenic patient's room.
Yes.
It feels like an annoying hospital policy to the family, but those beautiful flowers harbor microscopic fungal spores and bacteria in the standing water and dirt.
To a patient with 0 soldiers to fight off an infection, a bouquet of roses is literally a biological weapon.
Let's follow that idea of toxicity for a second. We've established how insanely hazardous these drugs are inside the patient, but that toxicity doesn't just, magically evaporate the second the IV pump finishes.
Not at all.
And cancer care is rapidly shifting to outpatient and home settings. Patients are going home wearing continuous IV chemotherapy pumps or taking highly potent oral chemotherapy pills right at their kitchen tables.
Which turns residential homes into potential hazardous material sites.
Mm-hmm.
The research shows that hazardous traces of these chemotherapy drugs remain in the patient's bodily fluids. We're talking urine, stool, vomit, sweat, and semen for roughly 48 hours after the administration ends.
That is wild. So let's paint a picture of a practical bedside discharge scenario. You are sending a patient home. What happens if they drop an oral chemo pill on their kitchen floor and it shatters? Or, what if their continuous IV line snags on a doorknob and leaks chemo fluid onto the rug?
So every patient going home with these treatments must be provided with a bright yellow home spill kit. Part of your nursing priority is teaching the patient and their family how to actually deploy it.
Right, because they can't just grab a normal sponge.
No, absolutely not. If a spill occurs, they must put on 2 pairs of disposable gloves, use specialized absorbent pads or heavy paper towels to soak up the liquid, and then clean the area meticulously with dish soap and water.
And then what do they do with the towels?
They have to double bag all of that contaminated waste.
Double bagging is key. And the everyday bathroom education is just as intense. We have to teach the patient to always close the toilet lid before they flush and then flush twice.
Yes, that is so important.
Why? Because an open flush aerosolizes toxic urine or stool, splashing microscopic chemo-laced droplets all over the bathroom surfaces.
And caregivers also need distinct protocols too. They must wear nitrile gloves, specifically nitrile, because standard latex is too permeable for certain chemical agents.
Okay, so nitrile only.
Whenever they handle the patient's bodily fluids or soiled linens, and if the patient's pajamas or bed sheets get soiled with sweat or vomit, they cannot be tossed into the washing machine with the family's clothes.
Oh, that makes sense.
They must be washed completely separately in hot water twice.
Washed twice in hot water. Got it.
Mm.
It's sobering to realize the sheer power of the chemicals we are administering. Now, everything we've unpacked so far involves chemotherapy, which is a systemic whole-body treatment. Let's pivot to targeted, localized treatment.
Okay, yeah.
I'm talking about radiation. The nursing priorities shift drastically depending on whether their radiation is external, like coming from a machine outside the body, or internal.
Right. With external beam radiation, it's like aiming a highly concentrated high-energy X-ray at one very specific coordinate on the body. The systemic side effects are lower, but the localized damage to the tissue in that direct path is severe.
The skin in that exact area is going to undergo desquamation, right? It will look and feel like a severe, peeling, blistering sunburn. So the nursing priority is aggressive skin preservation.
You have to eliminate all sources of friction and chemical irritation. We educate the patient to wear loose, breathable cotton clothing over the site. No tight collars, no underwires.
And no lotions, right?
Exactly. They cannot apply any over-the-counter deodorants, powders, perfumes, or lotions to the irradiated area unless it is specifically prescribed by the radiation oncologist.
And here's a scenario that trips up a lot of people on the NCLEX and in real life, managing the pain of that burn. When a patient's skin is radiating heat and peeling, their immediate human instinct is going to be to grab an ice pack. Or, conversely, a heating pad to soothe the deep tissue ache beneath the burn.
And applying either of those will cause catastrophic tissue damage.
Wow!
You have to educate them. Absolutely no extreme temperatures, no ice packs, no heating pads. They should only wash the irradiated area with lukewarm water and a very mild, unscented soap.
And how do they dry it?
They must pat the skin dry with a soft towel.
Patting, never rubbing, because rubbing will literally shear the fragile, damaged epidermis right off their body.
Yes, exactly.
So that covers the external beam. But what about internal radiation? Brachytherapy. This is where radioactive pellets or seeds are temporarily implanted directly into a body cavity, like the cervix for cervical cancer or the mouth for oral cancer.
This is a really intense topic.
It is. Here is a wild bedside scenario for you. What happens if you are repositioning a patient in bed and one of those radioactive pellets physically falls out of their body and onto the bedsheets?
Your first instinct as a nurse is usually to grab whatever fell and put it back or, throw it away.
Yeah.
But the absolute first rule of brachytherapy is you never, ever touch that pellet with your hands.
Not even if you are wearing thick rubber gloves.
No, not even then. The strict clinical protocol dictates that you must use long-handled forceps, which must always be kept in the patient's room for this exact emergency, to pick up the pellet.
And then what?
You immediately deposit it into a specialized lead-lined container called a lead pig, and then you urgently page the nuclear medicine department.
Distance and lead shielding. It sounds like a scene straight out of a sci-fi movie, but it's just a Tuesday morning shift on the oncology floor.
Right. It perfectly highlights the immense diversity and technical proficiency required of an oncology nurse. You have to be part pharmacist, part hazmat specialist, and part psychological counselor.
Which brings us to the core of what we do. Oncology nursing is undeniably complex. But when you understand why chemotherapy causes a patient's mouth to ulcerate, or why a 100.4 fever in a neutropenic patient is a blaring siren, you are no longer just memorizing arbitrary rules.
No, you are actively applying real clinical judgment.
Exactly.
And that is exactly what transforms a novice into a safe, effective nurse. You aren't just blindly following orders. You understand the deep cellular physiology behind those orders.
The emotional takeaway I want you to carry into your next shift is the chart is intimidating, yes, but it makes sense now. And you can use this logic at the bedside tomorrow. You are the literal shield standing between your patient and the devastating fallout of their cancer treatment.
And for a final, highly practical takeaway, remember the golden rule of administering oncology medications. Always check your IV sites frequently for extravasation.
That is so critical.
It is. Because if that toxic drug leaks out of the vein and into the surrounding tissue, It will cause severe necrosis. And always be proactive, not reactive, with your nausea and pain medications. Do not wait for your patient to suffer before you intervene.
Proactive is the name of the game. Before we wrap up, a quick reminder to head over to YouTube and watch the visual breakdown of this topic on the Super Nurse Comics channel.
It's a great resource.
It really is. Make sure to like, subscribe, leave us a comment, and visit supernurse.ai for incredible resources that will help you become the super nurse you were born to be.
It's an amazing community, highly focused on bridging that gap between the textbook and the bedside.
I want to leave you with one final fascinating thought about the future of our profession. We spent all this time today analyzing chemotherapy, which we established as a blunt instrument destroying fast-growing cells. But the future of oncology is rapidly shifting toward immunotherapy, specifically checkpoint inhibitors. Instead of the drug attacking the cells directly, immunotherapy basically takes the molecular brakes off the patient's own immune system, allowing it to finally recognize and attack the cancer cells.
It is brilliant.
It is, but it raises a terrifying new question for the future bedside nurse. What happens when you remove the safeguards on a patient's immune system and it gets too activated? What are the nursing priorities when the body starts launching a severe autoimmune attack on the patient's own healthy organs, like their lungs or their liver?
That is the emerging frontier of oncology nursing, and it is going to require an entirely different paradigm of clinical vigilance.
Something to ponder as you look at those complex charts. You've got this. Keep learning, keep questioning, and keep connecting the dots. We'll see you next time on the Super Nurse Podcast.